privilege of engaging with the patient engagement platform from the Alberta Spore Support Unit on the committee, and also the chance to participate in some of these journal clubs before. So really appreciate the chance to come and share about our work. This was a real thrill to also have Isabel join today, and to be able to share in partnership with her a little bit about this work that we did actually a few years ago now. And so we can also share what we learned from that, but also where things have gone since that time, because I think that's been critically important. So I really appreciate the land acknowledgement that was already made. So I'm also here in Treaty 7 territory in Calgary, but I will turn it to Isabel to share where she is, which is not here.
No, I am not. I'm super virtual. So I'm very grateful to be logging on from the traditional lands of the Squamish people, more commonly known as Squamish, BC. I have the good fortune, since getting a puppy a couple of months ago, to have to walk him every morning through the trails, and just I have a lot of gratitude for the lands we're on and the people who kept them and continue to keep them.
So I wanted to start out, for those of you who don't know much about the area of pain in children, or perhaps some of you already do. This is a patient journey map that was actually created after the project we're going to share about today. And it was created in partnership with Isabel and her son, Zach, mapping out Zach's experience and their family's experience with pain from when Zach was quite young through to where he is now into adulthood. It probably looks very overwhelming and busy and chaotic and stressful, and also having some joyful moments along the way, because it is. So it is and moments, I think, that stick out for me, where you can start to see things like our family felt abandoned by the system, or going in circles, and other challenges. So I share it just to set the stage. We know that 1 in 5 youth deal with chronic pain before they reach adulthood. And there are many factors along the way that can contribute to the development of chronic pain, and many places we still need to go to improve that experience, and ideally to prevent it from developing in the first place. Isabel, do you want to add anything here before we move on?
Yeah, I've been asked to do patient journey maps before, or done very loose ones. And one of the really impactful thing for myself, and I think also for my son in doing this, was really recognizing the chaotic nature of our lives because of our travels through the healthcare system and interactions with them. It was a really good process for the whole family, really, to kind of see it laid out and realize that it's not us, it's the system.
Thanks, Isabel. So I feel like we're preaching to the choir a little bit as we come to this space, but I think it is important to identify some of the evidence that is behind, the potential and the value of partnership with folks with lived experience in health research. The evidence we do know, and I think there's even more since this time, suggests that when we partner with people with lived experience in health research and throughout the research process, that it enhances the quality and appropriateness and relevance, that it leads to more effective, efficient, and meaningful research to patients and families. It increases the likelihood that research will be taken up in clinical care, which then leads to better patient outcomes. We know there's a lot of research waste that happens in the world. So projects, research that gets funded, but don't actually ever have an impact, or don't actually reach those who can use it. And it avoids, it helps to mitigate the risk of that waste of research funds and efforts that just frankly aren't important to patients. So we can avoid these kind of intellectual endeavors for that purpose, and make sure that it's connected to what actually matters and what's needed in day-to-day life for people who actually live with that health condition. So our team, I was actually a postdoctoral fellow at the Hospital for Sick Children when I initiated this project, and put in a funding application for this project in 2016. And I did so after attending a 3-day patient-oriented research training through the Ontario Sport Support Unit, actually. Most of my research, I've been working in the field of pain for now 14 years. And I had done a lot of work based in the lab. I'd done some work with experimental pain tasks with families to try to tease apart mechanisms, psychosocial mechanisms, looking at what makes effective psychological interventions and so on. But I hadn't yet had the opportunity to truly partner with patients and families. And when I went to this 3-day sport support unit, I basically am also a clinician. I also do intervention with families and have worked within the health system. And I just thought more of this, sign me up for more of this. So I led a grant in partnership with Jen Stinson, who was my postdoc supervisor at the time. And we put forward this patient-oriented research grant. It was a relatively small grant to CIHR. And one of the parts of that was to do a priority setting partnership. And this method is put through by or promoted by the James Lind Alliance. It's known for its equity and rigor and its effectiveness and quality for partnering with people with lived experience to identify research priorities. And this was really needed in our pain space because researchers had certainly identified priorities for research, but had never done so in this way. So this voice was really missing. I think the other part I've recognized is the field of pediatric pain hasn't been around very long. It really started in the early 1980s, but it really started through the advocacy and lived experience of folks in the community. So at that time, it was standard of care, and it was widely believed that babies in particular didn't experience pain, that their brains were too immature to perceive pain the way that adults did. And as a result, pain care was not part of standard practice. So to give you a sense, if I had been born premature, I was born in the early 1980s, and I had to undergo heart surgery. That heart surgery would have been done with no anesthetic and just paralytic, so I wouldn't move. And that's exactly what happened to Jeffrey Lawson, who was born at 26 weeks gestational age. And it was his mom, Jill Lawson, who, when she learned that her son passed away after about 6 weeks of life, she took that to the Washington Post and said, "This is outrageous. That my child who's born premature can have heart surgery with no pain medications, just medications so that he wouldn't move," and just the atrocities connected with that. At the same time, there were some researchers that had started to look at the benefits or the outcomes for babies undergoing surgery who had pain medication versus those who didn't. And no surprise, those who got pain medications did better. So it really was the coming together of these two things, but critical to catalyzing the field of pediatric pain was this mother's voice and her lived experience. So I really feel like us prioritizing the voice of people with lived experience through this priority setting partnership in chronic pain just brings that full circle where it should have stayed from the outset, but it didn't. So as part of the James Lind Alliance priority setting partnership, we had a steering committee that included a number of different folks with lived experience, including youth living with chronic pain from across the country and parents and caregivers. We started out with a national survey that basically just asked, what are your priorities? What are your unanswered questions about preventing, treating, managing chronic pain in youth? And when I say chronic pain, I really mean pain that lasts longer than 3 months, often lasting many years. So more than 200 folks across the country, people who had lived experience directly, family members. We even had a boyfriend, I think, respond, which was great, and health professionals. They had 540 priorities. Following the JLA process, we combined these, removed duplicates, looked where things fit together, and came up with 112 research priorities. We then sent a portion of those, as per the JLA process, back out to 57 folks with lived experience or health professionals to select the top 25. And those top 25 were brought together for an in-person workshop that included youth, parents and caregivers, and a diverse group of health professionals across the country, which you can see a picture of that group in the corner there. We came together in Toronto in December of 2018 and went through a consensus process where we discussed and arrived at the top 10 priorities for pediatric chronic pain research and care in Canada. So that's what was presented kind of in the paper that that was shared. I want to show you a little bit of a video that came from this project so you can hear from some of the folks with lived experience and actually see some of that in-person workshop in action. My name is Katie, and I'm a psychologist, and I'm the lead for the Partnering for Pain project. Chronic pain in children is a really significant health issue, and it's really, a lot of research has been done to date and made huge strides over the last 40 years in understanding how pain is assessed and treated in children. But we've really left out one of the most biggest expert voices in this, in deciding what research should be done, and that's really of patients and families themselves.
I've always thought that there's a gap between research and patients and what they want to see researched and what they understand from research. I was in the beginning really encouraging people that I knew in my community to respond to the survey. So it ended up with 500 plus answers, and now we get to bring this all down to 10 priorities. So it's very exciting to see.
As a parent, I have to say I've felt helpless a lot of times along the way in what I could do to help Catherine. So when we had the opportunity to get involved in this research project, we jumped at the chance, and we've been involved since day one, to come together in a room with people from rural and urban and different age groups, different dynamics. There's a lot of variation in the voices in that room.
And it's been a fantastic opportunity to come into this project. I always say at many points in my career I am often schooled by patients and families, and that's happened to me today.
Being here has opened up my eyes about what options there are nationally in the rest of the world.
And as a mom of a child who is suffering with chronic pain, it helps me to see there is hope at the end of the tunnel.
Well, I think that this is just the beginning of everything. This is the spark that will ignite a wave of future in the research world.
I just want to say thank you so much for inviting me. I learned a lot, and I learned a lot about people and myself, and I just want to say thank you that you invited me to this wonderful event.
So I wanted you just have a chance to kind of see some of the different folks we had around the table, some youth, and we worked with our steering committee to ensure that the representation, the diversity that we had there felt appropriate, so that not only touched on things like sex, gender, race, but also different experiences with chronic pain, including headaches, migraines, widespread pain, sickle cell disease, and so on. As well as different experiences in care so far. So some folks who'd been seen in specialty chronic pain clinics at children's hospitals, and some folks who hadn't, folks who lived in cities, folks who lived on reserve, and so on across the country. And from a health professional standpoint, we had physicians, nursing, psychologists, physical therapists, and some other people as well. Here are the top 10 priorities we landed at. So what treatments or strategies effectively prevent acute pain from becoming chronic? What's the impact of chronic pain on academic performance and educational attainment? And how can we support youth in their vocational planning as they move into later adolescence? What physical and psychological treatments are effective? How do we improve access and delivery of treatments and coordination of care with a view to reduce disparities? What strategies effectively increase healthcare professionals' knowledge and communication about pain? How can we increase government and healthcare organizational financial support for this evidence-based care? How do we educate school personnel? How do we treat and manage acute pain flares that can happen? What about chronic pain and mental health? How can we better understand the intersection between these things? And how can they concurrently be effectively diagnosed and treated? And when are treatments most effective? Do we have to wait until medical investigation is complete? Does that vary based on the type of treatment that should be offered and when, medications, psychological therapies, physical therapies, and so on? And I think what struck me, I mean, there have been other efforts that have not involved folks with lived experience in their development to identify priorities in pain. What struck me as I reflected on these questions is the framing of them truly centers on the lived experience of people living with chronic pain and their families. To give you a really prime example, some of the other priority setting or research priorities that have been identified in pediatric chronic pain ask questions like, what symptoms for pain are a specific medication effective for, such as non-steroidal anti-inflammatories or opioids. That really focuses on the drug, right? What does this drug help for? I think what I see here, just to give you another example, question number 8, what interventions are effective for managing acute pain flares? It could be that one of those medications is helpful for that, but the question's really centered on what's going to make a difference in my life and what, it opens up the possibilities of strategies and interventions versus leading with, hey, this is the solution that we have. What does it work for? It's here's the problem. Here's what I'm looking to actually have better in my life. Now, can we think about what can actually help me to get there? So it's just one example, but I think the framing of the questions is quite different when we engage people with lived experience. We also did, as you would see in the paper, evaluation of patient and public engagement. We used the PEAT, but there are a number of different tools, some new ones that have come about also since we worked on this project. This is just a snapshot of what we asked the final priority setting workshop, which really reflected that we did quality, meaningful engagement across the board, including with youth, parents, families, caregivers, and health professionals. We were able to create a safe space, and people thought that their participation in it was meaningful, valued, and would lead to impact. So that was great to see. And I'll say, I think we've been able to continue doing that since the project's completion, which I'm quite proud of. But I think what I'll emphasize here is that it's important to evaluate and to ask. It's important to engage folks in the development of it, but you also to know whether you've done that well, and also to inform what you do moving forward. You need to evaluate what that looks like. Just before I turn it to Isabel, I just wanted to share some other quotes from patient partners who were engaged in the project. Catherine is a youth living with pain who partnered throughout and was a member of the steering committee, as well as engaging in the priority setting process itself. And she said, being a patient partner has given me confidence by focusing on my abilities. Being on a team of researchers and healthcare providers gives you the sense of having a community behind you. I never thought I would have the opportunity to play such a crucial role in a research project. And I think that also speaks, many youth feel, or are, I shouldn't say feel, they are stigmatized and dismissed by health professionals. And so the ability to partner and share power with her as part of this, I think, was quite meaningful to her. Esther, who you saw in the video, you saw Catherine as well. She said, it's great to have the patients and families' voices at the table because we have a different set of eyes. I think we need more of these opportunities across the country. And then just lastly, since we published this in 2019 and finished this work, we've been doing a lot of things to actually mobilize these into action. So we've been generating awareness and interest. There's a picture of myself there with Justina and Adam, who you saw in the video, both youth with lived experience. That was part of a lobby day on Parliament Hill in April of 2019 in partnership with Solutions for Kids in Pain, or SKIP. And they were able to meet with members of parliament, with senators, and so on, and really share their lived experience alongside folks like myself, clinicians and researchers who could back up their lived experience, which really was critical to indicate they're not alone. This is an issue and we have some solutions. So to raise awareness about that. We've been creating open dialogue. We've presented at conferences together. We met with different organizations, such as there's a collaborative in Ontario of all the pediatric chronic pain clinics in Ontario, met with them for a working collaborative dialogue to share the top 10 priorities, but have them start to brainstorm and action some of those together within their clinics. And then we've also been facilitating adoption of the evidence. Our priority setting partnership was cited in one of the reports for the Canadian Pain Task Force, which resulted in a third report in March of 2021, laying out an action plan for pain in Canada, identifying youth as a population disproportionately impacted by pain. And we can see some of the priorities we identified reflected in their recommended actions to improve pain care for Canadians. So now, since I finished my postdoc, I'm here at the University of Calgary and launched this into an independent research program called Partnering for Pain. And we're really working together, continued in partnership to actually action these identified top 10 priorities in partnership with people with lived experience and other partners, but also identifying new priorities and making sure that we are listening and evolving and responding to the emerging needs of folks with lived experience. So those are some example projects. So I'll turn this over to Isabel.
Thanks so much, Katie. It's fun to reflect back on working on that project and think about how it's impacted other projects that have come since. So this was a really special project for myself because it was the first one where I traveled with our daughter, Evie, who was then 14. And it was really her first opportunity to engage in a bigger project. So she was really excited. That's us on the plane on our way. We planned on going to the theater too. So, you know, there was that excitement. Hey, Katie, are you just going to flip slides as I go kind of thing? So when Katie asked me to co-present with her today, I said sure and didn't really think about it till a couple of days ago, to be completely honest. And I thought, you know, what was really important aren't my reflections, but on Evie's reflections. And I think she had a lot to give as far as what happened, because she really was one of the youngest people there. She hadn't taken part in something like that, and it had the potential for being quite an unsafe experience for her. I was nervous for her. I really wanted this to be a good experience. So I asked Evie, she's done other partnering opportunities since then, but I asked her if she could like go in the Wayback Machine and remember what she thought about this. And slide, Katie. And these are what was really important to her and what she remembers. So there was a real sense of safety around what was happening with that in-person workshop. And by that, what she means by that is that her voice was heard. She was taken seriously. She wasn't talked down to. And I asked her for some more concrete you know, what really made a difference for her. And really, it was a lot to do with Katie's leadership, not to, you know, blow smoke up your butt, Katie, but it's true. And what happened is in framing what we were going to do for those 2 days, Katie really emphasized by explicitly, but also by example, that the patient partner voices were really important, and just as important or more important than other folks there. Little things she remembers are when the introductions were going around the room like you do in these things, it wasn't the sense of it wasn't a competition of I'm Dr. So-and-so, and these are all the amazing things that I've done. It was just I'm whatever the person's name is. If it was a clinician, Dr. So-and-so, and I'm interested in this because, or this is what brought me here. And that made her feel like she belonged because she did belong. And one of the things that she really remembers about this, and one of the things that I thought was quite amazing, is that the patient partners, especially the youth, really led the way in terms of what was important in trying to figure out what the top 10 priorities were. And by that, I mean that there were some things that the youth wanted to change because they said we were going a little bit down the wrong track in terms of how we were wording things or what we were including or how to put things together. And that was really given as a this is their life. If this is what they say is important, then this is what we need to follow, even if it kind of required pivoting on how the process went for the Lind Alliance. And I was so very impressed with that at the time. I was impressed with all the youth there as well. They had so much wisdom, and the wisdom of others to listen to them and understand that patient partners, parent partners, caregiver partners have their own expertise to contribute and to recognize that. And when a leader of an initiative recognizes that, it helps everybody else participating to recognize that, creates boundaries around it. So that's, Katie, I don't think I've ever told you any of this stuff, but this is what Evie told me now at 18.
Awesome. Thanks, Isabel. When Isabel and I, because you've heard us start by saying, actually, we did this project a while ago now. So how has my practice, Isabel asked me this question because Isabel and I partnered since, and I've increasingly grown my partnership with people with lived experience and others. One of the things we were talking about was, how has my practice in patient engagement evolved since this time? And I went in neck deep, I'll say, in patient engagement with that as a first project. So it truly was, jumping into the deep end with great mentorship from folks with lived experience who are experts in this space, including a friend and colleague of Isabel and mine in particular, who's also in Toronto, Don Richards, and others. And Isabel's also a great expert and advisor, and we've continued to work together in that capacity on other projects as well. So I think that for me has been critically important, is that my mentorship in this space includes people with lived experience who are experts in this, not just in their lived experience as it relates to the topic of pain in childhood, but they're experts in partnership and the evolving practice of partnership. And I think has been absolutely key for me to I know folks look to me and say, you're a leader in patient engagement, Katie, and that's a huge honor and privilege. But I do that by humbly listening to others and really learning from others who I truly see as experts in this space, and who can reflect back and say, this is quality or this isn't quality engagement. But one of the concerted efforts I've really made has been working to increase the diversity of folks that we're partnering with, really intentionally. So I put up here just some examples so you can also see how we've recruited for folks with lived experience for additional projects on social media. But we also, what you see on the right-hand side is a bit of a description, almost like an opportunity, an engagement opportunity, that the structure of which we co-created with youth and parents and caregivers, almost looks like a mini job posting in a less job threatening kind of a way, but really to give them some information and start to think about, do I want to know more? Am I curious about this? But really being intentional to say, we're looking for folks who are Black or Indigenous or other people of color who identify as people with disabilities, and partnering with organizations who represent, support, advocate on behalf of those communities, recognizing my own power and privilege and positionality, as a white cisgender female settler in Canada and in Calgary. And a psychologist, right? And researcher. So I hold a lot of privilege in these spaces. And we've really evolved in how we're doing that. So this is just a snapshot of some other projects, really responding to some of the priorities in response to the pandemic, but also in responding to the top 10 priority to increase access to care with a view to reduce disparities. We mapped out best practices for virtual care during the pandemic for youth with chronic pain, identified new innovations, and have really included patient partners in a variety of different ways. And on that particular project, these are the myriad of ways we partnered with folks with lived experience. So we had a number of partners who were equal members of the research team, including 5 youth, young adults, 4 parents and caregivers. We did a national call for virtual care innovations in partnership with some organizations. And then those that were submitted were reviewed by an additional advisory panel, which had merit reviewers, which had 1 youth and 3 parents as part of it. We had other parent and patient advisors who contributed to one part of the project, where when we mapped out all virtual care solutions that existed in the literature and through the app stores, and we were deciding what do they want to know as part of this, part of any virtual app or intervention for chronic pain. And they said, well, we want to know, does it capture information about medications or school, or which psychological interventions or sleep, or, has this been used by others? What did they say? Who is it for? They helped us create that kind of coding scheme so that when we put that out there, people could filter the information about virtual care apps that were available by what they wanted to know about, what they thought was important. And then when we'd identified best practices for virtual care for youth with chronic pain from the literature, we did a scoping review. We recognized most of the research that had been done with white youth, who are predominantly those that are seen in chronic pain clinics. So we did an additional project where we took those best practices from the literature, and we had collaborative dialogue sessions specifically with Indigenous youth and families, youth with complex medical needs and neurodevelopmental disabilities, and Black youth with sickle cell disease, and then modified the best practices for virtual care based on, informed by the evidence, but also by their lived experience, so that what we put out there in the world was more inclusive, and really put forward equity and accessibility in best practices for virtual care for youth with pain. We also have been actioning the first priority of how do we prevent acute pain from becoming chronic by co-designing new health services together. So I think also in the methods we select, again, folks with lived experience as equal members of our project team from the beginning through our grant to CIHR and so on, but also using human-centered design or co-design methodology that really center the lived experience of youth with pain, in this case, undergoing surgery, who develop chronic pain after surgery. But also we created a new blueprint, a service for a new health service that improves the surgical pain management experience for those who are at risk of developing chronic pain after surgery. Youth were there, parents were there alongside different health professionals and hospital administrators.
Thanks, Katie. So we're kind of getting to the point of one of the things I think about is how things have changed and what I'm learning. And I didn't actually put it on the slide on this slide, but Katie reminded me. One of the things that I really learned is that the expertise that I've personally developed and people like me have developed in partnering isn't just on our lived experience, but it's also on what works and what doesn't work in partnering, and what best practices and patient partnership look like. And we're beginning to see more of folks like me, people who don't have a background, academic background in partnership or engagement, but have a personal background with it. Taking some positions of mentorship, coaching, advising. And I think for me, that's really important because it's important to know how to partner well. The biggest, I think, take home is that patient partnership is always changing. It's a moving target. I hate the word journey, but it's a journey, not a location. And we're all learning together on it. One of the things that I try to address, and I think Katie does really well, is not being stuck in old practices, but even if they're published old practices, and rather listening to patient partners on what works or what's new or what's innovative when it comes to partnering. And, we're all learning together. It's not just the professionals in the room, but it's patient partners. It's folks like me who advise and coach. It's all something we bring to the table, and we all make mistakes in it, and we're all learning. And that humility to understand that mistakes are always going to be made, but acknowledging them and moving forward and finding solutions. That's how we build trust, not trust apparently, but trust on my slide. See, mistakes. And one of the things that I've seen really changing, depending on who I work with, is that acknowledgement that patient partners are subject matter experts on a team and need to be treated that way, and expertise needs to be recognized that way. And that hasn't always been the case. You know, a lot of engagement practice involves telling story and, you know, trying to walk in somebody's shoes, which I think is not possible, but really to listen to us as experts and having knowledge that can't be accessed, isn't by anybody else in the team because they don't have that experience. And I'm seeing more of that, and that's really exciting. So that's what I've learned.
Sorry, I was trying to find the unmute button. We just want to end by acknowledging, you know, all the folks with lived experience who've partnered in this particular project, as well as many others. And just put up our contact emails as well as on social. And then, of course, you can learn more about this particular project, the video I showed, all the other work that we've been doing to action these top 10 priorities, and partner with folks with lived experience on the website. And then Isabel and I are also going to make a plug for something else happening tomorrow. So we both do work with Solutions for Kids in Pain, which is a national knowledge mobilization network in the area of children's pain. So really bridging that gap between evidence-based solutions and what's actually happening in the real world. I've been chair of the national working group that's worked for the last 3 years in partnership with the Health Standards Organization. And we launched the first national health standard for pediatric pain management in Canada and in the world on April 3rd. It focuses on quality, equitable pain management for children in any hospital in Canada, and provides 34 recommendations for organizational leaders and health professionals in how to achieve that. It's free. So you can click that QR code to access it for free, but there's also a public town hall tomorrow that both myself and Isabel are speaking at, along with Julia Hanigsberg, who's CEO of Holland Bloorview Kids Rehab Hospital in Toronto, and Regis Villancourt from the Health Standards Organization as well. So if you're free to join us, we're in Alberta, so it's 10:30 to noon tomorrow Mountain Time. But free and certainly happy to connect about that as well. And that was what we wanted to share. So we look forward to questions, discussion for the next 15 minutes or so.